Okay. Very good evening, good afternoon, good morning, depending upon the time zones of people who have joined for this meeting. Welcome to this combined program of GAPIO and ISG. GAPIO stands for Global Association of Physicians of Indian Origin. And I bring in greetings from Indian Society of Gastroenterology. I am Mathew Philip, the Secretary General of Indian Society of Gastroenterology. And today we have selected very interesting topics. I know that alcohol-related liver disease is very rampant, and very specific topic, acute liver failure, how to diagnose, how to actually refer these patients to a institute, and all this very relevant in general practice. So to introduce and the speaker as well as the subjects, I am having Palaniswamy, who is the moderator, and he is actually the HOD and senior consultant of gastroenterology at Apollo Hospital, Chennai. He was awarded Padma Shri, and also he had received the Lifetime Achievement Award of Indian Society of Gastroenterology. I welcome Dr. K R Palaniswamy and start the proceedings. Dr. Palaniswamy, please.
Yeah, good evening. I would like to thank Dr. Mathew Philip for the opportunity to be a part of this meeting today. I'll be very happy to introduce our chairman, Dr. Mathew Philip. Mathew Philip is a senior gastroenterologist with more than 33 years of experience, currently head of gastroenterology and hepatology in Lisi Hospital, Kochi. And special areas of interest are IBD and therapeutic endoscopy. Dr. Mathew has more than 62 publications, including abstracts, research articles, and chapters in textbooks. And Dr. Mathew is also a peer reviewer of multiple journals. Dr. Mathew is also the editorial board member for the Journal of Digestive Endoscopy. So with that introduction, I would like to we'll start the meeting. I think today we have 2 lectures, and the first lecture will be by Dr. Santhosh Kumar. Dr. Santhosh Kumar is the Associate Professor, Hepatology Department, CMC Vellore. So Dr. Santhosh Kumar will be talking on the alcohol-related liver disease. Can I request Dr. Santhosh Kumar to start his presentation?
Thank you, sir. While the slides are coming up, I'd like to thank GAPIO, the organization, for this opportunity, and I bring greetings from CMC Vellore, especially the hepatology department. Are my slides visible now?
It is visible.
So
before starting, on housekeeping, this actually, all those who are participating, please post your questions in the chat box. We'll try to answer that, and we can put while listening to it, or before that, you can actually put across that. We will have the discussion at the end of after both the talks. We'll have the question and answer session together. Sorry, Santhosh, carry on.
Yes, thank you. So the topic that is given to me today to discuss over the next 20 minutes is alcoholic liver disease. It's a wide topic. I'll try to do as much justice in 20 minutes. So what do we mean by alcoholic liver disease? Obviously, it's a liver disease that is caused by excessive and prolonged consumption of alcohol. It encompasses a spectrum of disorders, starting from simple fatty liver, that is hepatic steatosis, going on to a more fulminant inflammatory syndrome such as alcoholic hepatitis, to advanced fibrosis. It might be cold or hot case, as patient who is having cirrhosis, walking around in OPD versus somebody who's decompensated, has jaundice, has complications, and the most severe form of all, acute on chronic liver failure. Sometimes in practice, we realize a fatty liver patient with alcohol binge for 5 to 6 months suddenly from hepatic steatosis phase can jump on to alcoholic hepatitis and straight to acute on chronic liver failure. So these order of progression may not hold good always, especially when the alcohol consumption is in huge amounts. So do all people who take alcohol develop liver disease? There is 80% of people developing steatosis recorded in literature, 35% of people go on to develop steatohepatitis and fibrosis. 10% develop cirrhosis, and 1 to 2% progress to hepatocellular carcinoma. So we know that in today's practice that a person who consumes alcohol can also be obese. So there is a lot of overlap with MASLD or NAFLD. So this progression may vary to a much faster progression if there is concomitant other viral or MASLD predisposition for them to progress. Alcoholic hepatitis is a very fulminant presentation of this disease. So I will be talking about alcoholic hepatitis in detail. The same information which I had shared in the previous slide. From a normal liver, 80 to 90% go on to develop steatosis as seen in that picture, going on, and 20 to 40% progress on to fibrosis as seen in the pathology specimen below, and cirrhosis develops in about 8 to 20%, and HCC is seen in about 3 to 10%. But alcoholic hepatitis is a spectrum that can happen at any stage with excessive infiltration of fat and inflammatory infiltrate leading on to a acute on chronic liver failure and further worsening the present situation of the patient. So who are at risk of developing alcoholic liver disease? Women are more prone to develop cirrhosis compared to men because they generally have a lesser ability to metabolize alcohol. People who are obese for earlier said reasons have higher chance of progression. People who have binge drinking alcohol and cigarette smoking due to increased reactive oxygen species generation are at higher risk of developing cirrhosis. The only confirmed genetic risk factor is PNPLA3, which, if found, predisposes the patient to develop alcohol-related cirrhosis. So the most frequently asked question is what is a standard drink and how much of alcohol is bad? I mean, as doctors, we should tell patients any amount of alcohol is bad, but I'll be concentrating on what is a standard drink. So with this picture in mind, I'll go on to the summary of the information that is given in this picture to day-to-day practice. So I think most of us in practice will agree that a person who has harmful alcohol use is going to be drinking either 40% volume by weight of alcohol, which is whiskey, brandy, vodka, gin, rum. So a standard drink is 1.5 ounce, which is 45 ml, which is what we understand easily, contains 15 grams of alcohol. And between a lager beer to a strong beer, some people say 350 ml of a lager beer contains 15 grams and 250 ml of strong beer contains 15 grams. So in practice, what does it mean? So if some patient tells you he takes a male taking 1/4 of whiskey, brandy, rum, vodka, gin, any of the drinks, 60 grams is 1/4. So if he consumes more than 1/4 a day, or even if he consumes 1/4 a day, he is having harmful alcohol use. For a woman, this is much lesser. 40 grams is enough on a daily basis to be considered as harmful alcohol use. Between beer, if considering that in Indian setting, most of the big beer bottles are 650 ml, 1.5 to 2 times of that amount is harmful for men and much lesser for women. So what we have said in the last slide is what is harmful alcohol use? More than 60 grams per day for men or more than 40 grams per day for women for at least 6 months is considered significant alcohol consumption. Briefly about the pathophysiology, why does the alcohol affect the liver? Because it's predominantly metabolized by the liver. And there is a oxidative metabolism via alcohol dehydrogenase enzyme to produce acetaldehyde. This process happens via cytochrome 2E1 in the endoplasmic reticulum. And when alcohol is in higher concentration, this can happen besides liver and other tissues also. This process is a reactive oxygen species producing process. Similarly, when acetaldehyde is metabolized to acetone, that is also an oxidative pathway generating reactive oxygen species. So a chronic alcohol consumer has depleted glutathione and making their liver and their hepatocyte vulnerable to oxidative stress. So heavy alcohol consumption also leads to high triglyceride and fatty liver, which is what is seen in the initial stage of alcoholic liver disease. So from now on, I'll focus on alcoholic hepatitis because I think as physicians or audience, if they recognize alcoholic hepatitis, it needs special attention. So the National Institute of Alcohol Abuse and Alcoholism defines alcoholic hepatitis as an entity with rapid onset of jaundice as defined by more than 3 milligram per deciliter of bilirubin, raised AST more than 50 and AST to ALT ratio more than 1.5. That means the AST or SGOT is more and it's usually more than 50. But the definition also says it should be typically less than 300 or 400. In a person who takes alcohol for more than 6 months but has a period of abstinence of at least less than 60 days. So it cannot be abstinence beyond 2 months, and then we cannot implicate alcoholic hepatitis. Though sometimes in practice we find a patient looks like alcoholic hepatitis and has stopped alcohol much earlier. The definition makes it a definite alcoholic hepatitis only if there is biopsy. So we know in clinical practice these patients are having SIRS, they are looking sick. So we are not going to biopsy everybody. With the lack of biopsy, we can make a probable diagnosis of alcoholic hepatitis, which is what we do in practice. But it can be comfortably made with significant history of alcohol, with most likely a palpable hepatomegaly, features of SIRS, and laboratory features of LFT derangement, PTINR elevation, as told in previous slides. And possible alcoholic hepatitis is diagnosed when there is unclear history of alcohol consumption and when there is other concomitant etiologies such as drug-induced liver injury or viral, confounding when we are not able to make a clear distinction of what is the etiology, we should put a possible diagnosis of alcoholic hepatitis. Briefly into what is the pathophysiology of alcoholic hepatitis. So alcohol causes tissue damage to liver and it causes mucosal injury as well. So there are damage associated molecular patterns DAMP, and because of mucosal integrity loss, there is entry of gut microbiota into the system, and there is pathogen associated molecular pattern PAMP, which are in circulation. Once that increases in the system, there is a syndrome of autoinflammation that is triggered, with liver being the centric foci of inflammation. Kupffer cell activation happens. There is a IL-1, IL-6, TNF-alpha production, and this is a upregulated state of inflammation which propagates and continues into a downstream unless we intervene and stop it. So briefly, PAMPs and DAMPs are associated with liver damage, and innate immunity is triggered, macrophage activation occurs, and endothelial activation, which is VWF-mediated microvascular injury, occurs in alcoholic hepatitis. I'll roughly run through 1 or 2 studies from our center done by my colleague, Dr. Vijay. So the image has first column, sorry, the first row, which is a graph, which on x-axis you're seeing MEL score and y-axis is various markers of ferritin, CD163 and VWF. Ferritin and CD163 are markers of macrophage activation, and VWF is a marker of endothelial activation. We can see with the MEL score increasing, these things are increasing linearly with a good correlation. Similarly, SOFA score, which we know is a good marker of clinical deterioration because of inflammation, is correlated well with ferritin, CD163 and VWF. So we know alcoholic hepatitis has a macrophage and endothelial activation. Interestingly, in that particular paper, what we found is higher the level of CD163 and higher the level of VWF has got a worse outcome compared to a person who's got a lower CD163 and a lower VWF. So as practitioners, what should we be doing? So severity assessment. There are various severity scores which have been described. I will focus on 2 scores which we use at baseline in regular practice, that is discriminant function and MEL score, and 1 score that is the Lille score, which on steroid assessment of whether they are responders or not. This slide sort of summarizes the information of all the scores, focus being on Madrid's discriminant function, which the paper original came in 1982. Though it has a area under the curve of only 0.67, it's been traditionally used, and most practitioners are still comfortable using MDF as a score of severity assessment. A score more than 32 indicates severe alcoholic hepatitis. And severe alcoholic hepatitis is associated with higher 28-day mortality. And steroid therapy is recommended if the score of more than 32 is found. And MELD score we know is useful in chronic liver disease. Dr. Vijay will probably talking about the usefulness of MELD in acute liver failure. But MELD is also a marker of inflammation and alcoholic hepatitis. The MELD correlation with the outcome is area under the curve of 0.82. It's got a good sensitivity and specificity to predict outcome at 1 and 3 months. The LIL score, I will be talking about a little bit detail in subsequent slides. So conventionally, people call alcoholic hepatitis severe or not severe, whereas the NIAAA, which is a body which uh, decides a lot of things for alcoholic hepatitis and alcohol-related liver disease, has defined alcoholic hepatitis into 4 categories: mild, moderate, severe, and very severe. And they have used discriminant function and MELD to do this. So as we see, if the MELD and DF are less than 30, MELD is less than 10 and DF less than 32, it becomes mild. When the MELD increases but DF is less than 32, it is moderate. When DF is more but MELD is DF is more than 32 and MELD is more than 20, it is severe. And a very severe group is when DF is more than 60 or MELD is more than 30. I want the audience to pay attention to this because the subsequent slides will be referring back to this information. So treatment, the treatment of alcohol liver disease is definitely holistic care. We cannot treat alcoholic liver disease as hepatologists or gastroenterologists alone. So we need the help of psychiatrist to help the patient be having detoxification for alcohol, de-addiction. We need the nutritionist to come in because these people are usually nutritionally depleted. We need to give them adequate vitamin supplement, calculate their calorie and protein deficit and supplement it. That would be the primary management in the initial phase. And if there is an alcohol use disorder, how do we get the patient out of it? Good counseling, all of that are absolutely vital. Going on to medical management, what is been studied time and again for alcoholic hepatitis is prednisolone. The original paper in NEGM by Remond et al. Came in 1992, where they said patients treated with steroids had a 28-day outcome, which is better than people treated with placebo. And this benefit they have said is noticed beyond 6 months as well. Following that, there was multiple RCTs addressing this, but most other studies failed to show such a stark difference between the steroid arm and the placebo arm. So the Cochrane meta-analysis that looked at this 2 years back had compiled the data from 16 RCTs with 927 participants and 934 participants. The overall verdict on this is that steroids may not be beneficial in decreasing the all-cause mortality at 3 months. And there is also no evidence of occurrence of serious adverse effects that was noted in this systematic review. Having said that, for lack of other medical management, a lot of practitioners do use steroids with caution because there is a risk of infection. But in the initial phase of use of steroids, which is 40 mg per day regularly for 28 days, we cannot go on if the patient is not responding. So LIL score was a paper Lovett et al. Had published in 2007, where they looked at determination of responders versus non-responders. And the baseline parameters are age, creatinine, albumin, and prothrombin. Bilirubin is taken at baseline and day 7 after initiation of steroids. And most medical apps have LIL score. And if a LIL score is less than 0.45, that means they are responders. They have a good outcome. And if LIL score is more than 0.45, they are poor responders and they should be stopped of steroid therapy and upgraded to a better treatment. While this is there, STOPA trial came in 2015, published in NEGM. It was a 2x2 factorial design. They have compared prednisolone to no prednisolone, pentoxifylline to no pentoxifylline, and prednisolone to pentoxifylline. In this study, I'll just summarize that prednisolone tended to be showing mortality benefit, though not statistically significant. However, the arm that received prednisolone had reported higher infections. That was the take home from STOPA, and I'm also bringing up STOPA trial because pentoxifylline, which some practitioners still use in this particular large RCT, did not show any mortality benefit. So most hepatologists have stopped using pentoxifylline now. So we said if they are non-responders to steroids, they should have a better treatment. What is better treatment? Mathur and et al. Had looked at in 2011 early liver transplant for patients with severe alcoholic hepatitis. This was a case control study. So 26 patients underwent liver transplant and matched 26 patients were considered as control. They were given only standard medical treatment. There is a stark difference, 71% survival versus 23% survival. Transplant had a better outcome at 1 year. It is going on to 2 years also. So is transplant easy option? I think most people in seeing these patients on regular basis will agree it's not, because in a cadaver transplant program, you have a wait list of patients and we cannot place a severe alcoholic hepatitis patient there. And in a live donor setting, sometimes the family is not forthcoming to donate because of ongoing alcohol. So it is a difficult problem. Some people may argue you are giving higher rank because these people are more sick. This might affect the list, and these people also have recidivism at 10% at 1 year and 17% at 3 years from previous studies. So the jury is not out with regard to whether transplant is the option, but we know that there are practical difficulties of doing immediate transplant for these patients. So there is a need for other experimental therapies. 2 years back, from our center in CMC, we had looked at this paper. We have collated the data of patients with severe alcoholic hepatitis undergoing plasma exchange and compared that with controls who underwent only standard medical treatment. I would just like to draw your attention that these are very sick patients. Bilirubin median was 23. Their MELD score median was 31 and 37. Their discriminant function was 85. So these are really sick patients. And as we can see, the plasma exchange arm performed better than the standard medical treatment arm, and that benefit seemed to be sustained over a 1 year follow-up. And with regard to what plasma exchange we did a low volume plasma exchange. That is, we calculate the patient plasma volume and do 50% of that volume, and also give these patients low dose steroids, that is 10 or 20 mg of steroids for a period of somewhere between 1 month to maximum of 3 months we have given. Now, taking that study further, we looked at two types of plasma exchange, one being centrifugal plasma exchange and other being membrane plasma exchange. These are types of filters or other technique that used to separate plasma. And we found that centrifugal plasma exchange compared to standard medical treatment and centrifugal plasma exchange compared to membrane plasma exchange was the preferred technique of doing plasma exchange. So in our center, more and more for these alcoholic hepatitis patients we are doing, but these are not simple patients. So these are very severe alcoholic hepatitis, that is DF more than 60 or MELD more than 30. And we also treated these patients with low dose steroids. And we believe that centrifugal plasma exchange has improved outcome. Other experimental therapies, there are many in pipeline and many already published. I'll just focus on fecal microbial transplant because 3 studies from ILBS looking at this was done. And this is the latest from their team, and they are showing that intention to treat FMT arm performed better than prednisolone arm in a randomized controlled trial. However, there are again practical difficulties in doing FMT in regular practice. So I'd like to conclude my talk. There are a few learning points which I want to emphasize on. So alcohol-related liver disease is a spectrum, starting from asymptomatic steatosis to acute on chronic liver failure. I have focused on alcoholic hepatitis, which is a severe manifestation with worse outcomes. The core pathophysiology is macrophage activation syndrome and endothelial activation. Discriminant function and MELD are the most notable prognostic markers in regular practice. Holistic care with focus on nutrition, vitamin supplement, and psychiatric input is needed. Steroid therapy is still considered as a standard of therapy for severe alcoholic hepatitis. However, most people are little wary of using steroids in such sick patients for fear of infections. Early liver transplant is considered to have improved outcomes with a lot of controversies around it. Plasma exchange, we believe in our center with low volume plasma exchange and low dose steroids improves outcome of these patients. Thank you again for the opportunity.
Thank you, Dr. Santhosh Kumar, for the excellent talk. We shall take up the questions at the end. We shall move to the next talk by Dr. Vijay Alexander. Dr. Vijay Alexander is the Associate Professor of the Hepatology in CMC. Can I request Dr. Vijay Alexander to begin with?
Thank you, sir. I would really like to thank the organizers of GAPIO and IST for giving me this wonderful opportunity. Over the next 20 minutes or so, I hope to take you through a brief overview of acute liver failure, and it's a very extensive topic, so I hope to cover some relevant parts of it, especially with relevance to practice as a physician and an internist.
Vijay, can you just check your audio? There's some, yeah, now it's better.
Yeah. See, so a brief overview of the talk. I would talk about definition and syndromic diagnosis. How are we going to approach a diagnosis of acute liver failure? What investigations would be relevant here? And then to briefly look at management, which will include medical management, liver transplantation, and then to briefly touch upon the role of plasma exchange. So we'll start with the case. Here,
Dr. Vijay, still there's a disturbance in audio.
Yes, sir.
There's audio disturbance, Vijay. Not sure.
Okay. How about now? Is it better, Santhosh?
Yeah, it's better. It's coming again.
Yeah, it keeps coming back.
Okay, I'll just keep going. Just let me know if it is coming again now. So here we have a 16-year-old male who has presented with history of low-grade fever and lethargy for 5 days, noted to have yellowing of eyes for 2 days by the family, and then the fever subsequently subsided. But there was no history of water behavior. There was no significant past medical history. There was nothing in the personal history as well. On examination, he was noted to have icterus. He appeared dehydrated, and examination was unremarkable except for just a palpable liver. On doing some, I've just put up some investigations which were done. So his complete blood count was normal, all cell lines were normal. On LFT, his total bilirubin was 7.5, direct of 5.6. His enzymes were elevated, his GOT of 850,
Vijay,
SGPT of 1500.
it's getting bad. It's quite noisy. Can you just see if you can disconnect and disconnect your audio jockey once and sorry, it's quite noisy.
Yeah, sorry, just give me 1 second.
You can start sharing now. Yeah.
Is the audio better now?
There are some disturbance.
Yeah, it's coming.
Okay. Sure. So on testing, the LFT was noted to be abnormal with a high bilirubin, 7.5 and 5.6. Enzymes were elevated, almost more than 1,000. His INR was 2.8, and his hepatitis E virus IgM antibody was positive. So if we are to look at a syndromic diagnosis, I would just like all of you to just think about what the syndromic diagnosis here would be. Etiology is quite clear that it is hepatitis E. There are no complications that can be noted at this point of time from the data that has been given. But what syndrome would he fit into? Over the next 2 days, he goes on to develop irrelevant speech and altered sensorium. And on examination, we can see that he has some flaps present. So now, would your diagnosis of syndrome change? If so, what? So I'd just like all of you to just take 5 seconds to just think while I move on to the syndromic definitions of ALI and ALF. So before I start, I'd like to state that there is a prerequisite that we need to have a normal baseline liver function. That is, there should be no pre-existing liver disease when we are invoking a diagnosis of acute liver failure. Acute liver injury is an antecedent process prior to acute liver failure, where there is hepatic dysfunction, which is jaundice, and coagulopathy, which is defined as an INR of more than 1.5. If the pathology continues to progress, and then they can go on to develop acute liver failure. This is acute liver injury along with altered sensorium or hepatic encephalopathy. We are going to keep hearing about this jaundice to encephalopathy interval because it has got some prognostic implication as well. So we can, based on the time duration between jaundice and encephalopathy, we can classify it as hyperacute, acute, and subacute. Hyperacute is up to 7 days, and anything more than 7 days is acute. I will come back to this in as we talk about prognosis. So there are very many definitions of acute liver failure, but what is key to making a diagnosis of acute liver failure would be the presence of hepatic dysfunction, which is jaundice, coagulopathy, and then encephalopathy. Now, what is the basic premise of ALF? So we have a normal underlying liver. You have an acute insult, which we will come to what the etiologies are. There is jaundice or hepatic dysfunction. There is coagulopathy, followed by encephalopathy. So I hope we are all comfortable in making a diagnosis of acute liver failure at this point of time, at least as far as the syndrome is concerned. Now, before we jump into making a diagnosis of ALF, is there anything else we need to think about? So we have a patient with jaundice, fever, and encephalopathy. So in our setting, I think especially as an internist, there are some differentials that would be relevant. The most important of these would be tropical infection. So always it is okay, especially in the setting of significant fever that is ongoing along with jaundice. It is definitely good to think about malaria, dengue, scrub, leptospirosis, and enteric fever. And of course, having said this, I would like to stress on the fact that these should be looked at when they are relevant only. There are some other differentials that I have given, but most important would be causes of tropical jaundice. Now, going on to etiologies of acute liver failure, there is quite a bit of a difference between the East and the West. Now, the East, which is India and Southeast Asia, we see quite a bit of viral infections, mostly hepatitis A and E. Whereas in the West, the predominant cause of acute liver failure would be drug-induced liver injury. And while I say drug-induced liver injury, I mean overdose. And in this, the most important cause would be acetaminophen. Toxin-related hepatitis, that is rodenticidal hepatotoxicity, is being increasingly recognized in some parts of India, and Tamil Nadu and Kerala are two states where we see quite a bit of this. Overall, some common causes would include paracetamol, again quite common in the West. It's almost not seen in India at all. Drug-induced liver injury. While talking about DILI, I would like to draw your attention to ATT as a very important cause. Hepatotropic viruses, which include hepatitis A, E, and hepatitis B, shock liver or ischemic hepatitis. And then there are some rarer causes, but it would be okay to think about these. This would include autoimmune hepatitis, an acute Budd-Chiari syndrome with a fulminant presentation, and an acute Wilsonian crisis. Now, another group of diseases specifically seen in third trimester of pregnancy would be pregnancy-associated liver diseases, and the most important of these would be AFLP, or acute fatty liver of pregnancy, and preeclampsia bar HELP syndrome. Now, this is just to show some difference in etiology between the West and the East. In the West, the majority, 56.5%, is drug. Now, this is data from the All India Institute, where we can see that about 44% of those reported causes of ALF in their center was viral etiology. Now, acute liver failure is not a very common illness. However, when encountered, the prognosis may not be all that great. So this is a very high short-term mortality illness. Early identification of patients requiring liver transplantation would be key to favorable outcomes. There are many prognostic models that have been used in this setting. The most important of this would be King's College criteria. Some others include Clichy criteria, MELD, CPI, and Alphabet score. So we will just look at King's College criteria. This was originally described in 1989, and it was devised to determine indicators of prognosis in patients with ALF and to prioritize the need for transplant. Now, there are two separate criteria within the King's College criteria. One is for paracetamol and one is for non-paracetamol. Since we really don't see paracetamol, we'll just stick to the second half of the slide. So this is INR of more than 6.5 and any three of the following, which would include an indeterminate etiology. So we're really not able to pinpoint and say this is the cause of ALF here. Extremes of age, actually it's not extremes of age, but age less than 10 and more than 40. Jaundice to encephalopathy when it's more than 7 days. A very high bilirubin and an INR of more than 3.5. So all of these would point to a poor outcome in patients with acute liver failure if they do meet these criteria. Quickly to look at some investigations to send in these patients, definitely a complete blood count, a peripheral smear, a PT with INR. Now we keep coming back to INR because it's very, very important. And in those places where the facilities are available, it would be good to do a global viscoelastic test such as TEG or ROTEM. LFT, creatinine, lactate, and arterial ammonia are useful tests, and ammonia has been shown to have a prognostic role in outcomes of acute liver failure. Arterial blood gas, ultrasound abdomen. Ultrasound abdomen is to basically ensure that the underlying liver is normal. Viral markers, blood culture would be very important. If paracetamol is suspected, paracetamol levels could be sent, and then to look at other etiologies and an AIH profile and Wilson's workup, if relevant, could be sent. Now, going back to the case, Varun is now admitted to your center. He is drowsy, but he is arousable. You decide to shift him to your ICU and plan further management. But the ICU team wants to insert a CVC, and INR at that point of time on retesting is 5.6. So I want to ask a couple of questions, and I just want you to think, there may be no right answer here, but I can just point to what may be a reasonable clinical judgment in this situation. Now, first question is, how do we handle a line insertion with an INR of 5.6? Second question, do we think it's reasonable to sedate this patient with a bolus of a sedative drug, secure his airway, and prophylactically ventilate him before we do all of these things? We will come back to the answers to these, but to give a brief overview of the management principles. So one important thing would be to maintain minimal stimulation of the patient. Neurological assessment should be done frequently, and we should, especially if they have gone into encephalopathy, keep assessing them for their ability to maintain airway. As much as possible, avoid sedation whenever possible. Assessment of CNS function and HC grades become more difficult once a sedative drug has been administered. Now, coming back to the point of high INR in early ALF. INR is an excellent marker of prognosis in early ALF, and as it keeps going up, it tells us that the pathology is progressing. Now, it doesn't necessarily predict bleeding in early stages of liver failure, and this is something that we need to keep in mind. A high INR doesn't necessarily mean a high bleeding risk. Now, this picture will change as the pathology progresses and gets complicated by sepsis, or the patient moves into higher grades of acute liver failure or higher grades of encephalopathy. Coming to the question of how do we handle a line insertion with an INR of 5.6? Now, the answer here is really reassess the need for an invasive procedure. Is it absolutely needed right now? Now, if the answer is still yes, try and do a global viscoelastic test, which would be ROTEM or TEG. And it is likely to show that the prolongation of INR is not associated with a hypocoagulable state. Rather, they are more likely to be hypercoagulable. So, proceed with a guided access with no or minimal product support. Second question, is it reasonable to sedate him with a bolus of a sedative? Now, as I mentioned before, avoid sedatives whenever possible. And if needed, use the lowest possible dose of the drug. Propofol is a relatively okay drug. Now, two things to remember here. Many of these drugs are metabolized by the liver, and clearance of the drug from the system would take significantly longer. Second, once sedated, we do not know if it is the drug that is causing the low sensorium or that the patient is moving into higher grades of encephalopathy, and decision on transplant, decision on what to do next. All of this could be masked by this phenomenon. Invasive ventilation, I would say avoid prophylactically intubating, especially in early grades of encephalopathy. The key things to remember are, one is there an issue with airway protection? Definitely we should intubate. Second, high grade encephalopathy, not maintaining airway. Again, it is reasonable to intubate. Third, we are planning the transfer of this patient to a transplant unit or a higher center. And we're really not sure about the what is going to happen en route. So definitely it may be reasonable to consider intubation in such a situation. Going on to hemodynamic monitoring and management. So fluid resuscitation is rather important because they generally tend to be volume depleted, at least in early stages of the disease. A good target would be a MAP of 60 to 65 millimeters of mercury, maintain good urine output, and arterial lactate could be used as a target, but remember lactate clearance will also get affected as ALF progresses. Infections are a killer in acute liver failure, so have aggressive sepsis screens in place, take frequent surveillance cultures, chest x-ray, and initiate prophylactic antibiotics. Avoid invasive procedures when not really indicated. Fungal infections are also common, especially beyond first week of the illness. And if a patient is progressing and developing more issues and you're thinking sepsis is the cause, maybe consider initiating a prophylactic antifungal. Cerebral edema is again very often the terminal event or the killer in these patients. So anti-edema agents such as mannitol and hypertonic saline are useful. Just remember to monitor renal function while especially on mannitol. Coagulopathy, we have already covered this. Product transfusions could be guided by viscoelastic tests, but when there is active bleeding or if an invasive procedure is planned, please do give products as needed. Now, we can quickly look at some etiology-specific managements. One is to look at N-acetylcysteine. It is the antidote for paracetamol poisoning, and when initiated early on in those people with significant toxicity, it is life-saving. Now, there is increasing evidence, especially from the US acute liver failure group, that N-acetylcysteine has
Vijay, there is some sound issue there. Can you just check?
in
Vijay, you are not audible.
non-acetaminophen ALF, especially with early encephalopathy, tenofovir or entecavir. In heparin, acyclovir is a good drug to give. So is it better now?
Yeah, we can see your slides there.
Am I audible now?
You're audible. You're audible now.
Yeah. Sorry, I've been having some issues with power. So HSV infection, acyclovir is a good drug to consider. For AIH, corticosteroids. For Amanita, mushroom poisoning-related acute liver failure, penicillin G and silibinin have been used, but this is not something that we see very often. In pregnancy-related acute liver failure, emergent delivery is the etiology-specific management. In going on to quickly touch upon liver transplantation. Now, I would just like to make a mention that this is a very difficult decision. Reason being, timing the transplant is crucial. If we do it too early, have we subjected the patient to an unnecessary transplant when he would have anyway gotten better and recovered? If it is too late, is he too sick to transplant? So here is where a multidisciplinary approach becomes so important. So an intensivist, an internist, hepatologist, and a transplant surgeon are going to sit together, assess each patient on and at multiple points of time, and see if this patient needs a transplant. There are multiple prognostic scores, but King's College criteria has its own limitations because number one, we do not see paracetamol, and indeterminate etiology is quite common in our setting. Consideration of transplantation is needed in all patients with ALF, but this needs to be early on. At least the talk needs to happen early on. Now, whether they have a donor, whether this is practically feasible, now those are all logistics that we need to consider, but the consideration of transplantation needs to be early on. The questions to ask here are, is this etiology likely to be associated with spontaneous recovery? Is there worsening or improvement on dynamic monitoring with medical treatment? Is it an indeterminate etiology? And do we have those pointers to say that they are not likely to recover? This is just to quickly say that access to transplant for an acute liver failure, urgent transplant in India is rather difficult for financial reasons, for non-availability of organs, and for non-availability of access to super-urgent transplant. I would take maybe another minute or so to just wind up. Before that, I'd just like to touch upon the topic of plasma exchange. So this is an article that came in 2016, and it's a randomized control trial from Europe by Dr. Larsen's group, which showed that high volume plasma exchange has a mortality benefit compared to standard medical treatment and is associated with a better, statistically and clinically significant better transplant-free survival. Now, low volume plasma exchange is what we follow in our center, and this is a recent publication from our center where we have looked at 200 odd patients with rodenticidal hepatotoxicity. 32 of these patients met the listing criteria and were managed with plasma exchange, and 68.7% of them recovered and had that was the 1 month transplant-free survival. We found that presence of hepatic encephalopathy and a decline in MELD after the third session of PLEX were significantly associated with survival. And on the multivariate analysis, a delta decline in MELD by more than 10% was statistically significant, with a very good area under the curve. Now, to summarize, recognition of acute liver failure syndromically, and then to further go on and assess the stage of the disease, what is the etiology, what are the complications, is of prime importance. It is also important to consider some important differentials, especially in the right setting. Prompt initiation of supportive care and good intensive care can improve outcomes. Early discussions regarding liver transplantation should be done. Close monitoring needs to be
You are gone, Vijay. Again, you are gone.
Audio, Vijay.
Audio gone, Vijay.
Multidisciplinary approach, and we need all the intensivist, the physician, and the hepatologist to sit together and then decide on the need for a transplant. Thank you so much for your patient listening, and I apologize for all the glitches in between. Thank you.
Thank you, Dr. Vijay, for the excellent lecture. There are two questions in the chat box. We shall take up the first question. This is from Dr. Mathew Philip. Now we see a combination of alcoholic liver disease with NAFLD, that is MET-ALD. How to approach this group? How do we know fat or alcohol really cause that liver damage? Can I request Vijay?
Sorry.
Santhosh?
Yes, sir. I'll take the question. So thank you, sir, for the question. It's a very valid question because in today's practice, we know there's a lot of overlap between the two diseases. So there is a recent paper, both in the ASLD journal and in the ESL journal, which had looked at this, and they said people who have metabolic risk factors and who are taking alcohol should be coming under a criteria called as MET-ALD, that is metabolic liver disease and alcoholic liver disease overlap. So the spectrum varies between whether it's metabolic associated steatotic liver disease predominant or alcohol related steatotic disease predominant. So MASLD predominant or ALD predominant, MET-ALD. So if somebody is taking women 20 gram and men 30 gram of alcohol per day, and they have metabolic risk factor and have a fatty liver, it will be a MASLD predominant MET-ALD. Whereas if they're taking something close to 50 grams for women and 40 grams of women and 60 grams of men, and having a fatty liver, we should consider a alcohol predominant. So we could only say which is a more predominant, but met ALD, which is metabolic, and alcohol liver related disease is the new terminology that I'm sure is going to be increasingly used.
Dr. Santhosh, a question from me.
Yes, sir.
The role of biologicals in the management of alcoholic hepatitis, severe alcoholic hepatitis.
So Anakindra, there is a recent paper that was published, I think this year early part, which showed that there was some benefit, but again, Anakindra has been tried in the past also. Besides Anakindra, which is a IL-1 inhibitor, there is not been much of too much of biological that have been studied for alcoholic hepatitis in my knowledge. So Anakindra, some benefit, but not sustained.
Thank you. Question to Dr. Vijay. This is from Air Marshal Dr. Pawan Kapoor. What dose and what duration of consumption of paracetamol is likely to lead to acute liver failure?
So thank you for the question. With paracetamol, it is with regards to time duration, again, we do not see it, but from what I've read in literature, what is described is one is an acute ingestion where you have a toxic hepatitis. So this is somewhere roughly around 150 milligrams per kilogram. That would be what is toxic for an adult, if I'm not wrong. With regards to duration, so it's usually a suicidal intent and people take it all in one go. Whereas there is also a description of a slightly longer chronic intake in people who already have an underlying liver disease or significant alcohol intake, or they are on anti-epileptic drugs. So they do keep taking, especially in the setting of chronic backache and things like that. So they do tend to develop a toxicity as well. But what we are talking about and those leading to acute liver failure generally would be a massive and a one-time ingestion, something like 150 milligrams per kilogram. But I will have to recheck on those numbers, sir.
Question from me. I would like your comment on this artificial liver support in the management of acute liver failure.
Yes, sir. So that's not something that I really touched upon for want of time, but there are multiple liver assist devices that have been studied. The problem being, especially the most studied and widely known would be Prometheus, the MAS system. But the problem is that there is no, it was, whatever I can recall is that there is improvement, which is short term, but transplant-free survival and a full recovery has not been really shown. It is more of a bridge to transplant. As a standalone therapy, we do not have evidence as yet. There are other extracorporeal liver assist devices as well, but the most studied one would be Prometheus MAS.
Thank you, Dr. Vijay. There's one more question from Dr. Arun Garg. What is the cost of liver transplant at your center and how many are being done?
That is, I think, the cost and all, it varies upon the institution. So I think, that doesn't matter. It varies depending upon institution. Some institution will be low, it will be high. But I think, what are the indications and all of that is more important, and when to refer a patient. Cost is not a thing which can be discussed on this. It's okay.
Dr. Mathew, there's a question from you to Vijay. Do you think liver transplant numbers are coming down in ALF due to plaques?
Sir, I wouldn't put it that way, but I would think that there is a particular window where plasma exchange is likely to be very beneficial. So if we are if we are to identify these patients, we can prevent the progression of the disease and avoid transplant in them. So in a way, I would say it is crucial to identify these patients early on, start them on Plex, see if they're not worsening. If they're worsening, then we do need to consider transplant. So it is to identify early responders and non-responders. That is how I would put it. But plasma exchange does have a role in acute liver failure, for sure.
Can I ask a question to you again, Vijay?
Yes, sir.
Out of all the etiology of ALF, which would you, what do you think the most appropriate for Plex therapy?
So I will probably talk about what we have the most experience with, that is rodenticide. And we do have good outcomes, especially when a a non-liver organ is not injured, is not involved. By that I mean we don't have shock, we don't have renal failure. It's just liver and maybe hepatic encephalopathy. These are the patients who do well, but we do have to catch them early on. Too late in the game, it's just like transplant. You know, too sick to transplant would be something akin to too sick to plex as well. You know, there we have lost the window. So that is what I would say. We do have good outcomes in hepatitis A as well, but our numbers are rather small.
There's one more question from Dr. Dhirendra Rao. What is the role of cytotoxic edema in the pathogenesis of acute liver failure?
Okay, no, definitely, sir. That's a very important question and a relevant one. How hepatic encephalopathy differs in the setting of a cirrhotic and an acute liver failure, that is what this particular question would point to. So cytotoxic edema and cerebral edema, which comes on rather fast and predominantly driven by ammonia and other cytokines, resulting in neuroinflammation, would be key to the pathogenesis of cerebral edema and acute liver failure. This is quite different from the setting of chronic liver disease and a decompensated cirrhosis, which is why we do not use anti-edema measures there, but we do use anti-edema measures here. So I will probably stop with that and not go further into it, but it is key in the pathogenesis of cerebral edema in ALF.
Vijay,
Yes.
earlier in the past, because I was at King's College for some time, at that time, intracranial pressure monitoring was very rampant at that time.
Yeah. Yes, sir.
And do you think any role for that in the present setup?
Sir, we have actually almost the invasive bolted monitoring of intracranial pressure. I'm not sure it is practiced anymore. We have much better non-invasive techniques like transcranial Doppler, optic nerve sheath diameter, etc., which would really help us and get to almost similar results in terms of monitoring. So invasive bolting and parenchymal bolts, which is rather invasive, especially in someone who is coagulopathic and quite sick, I don't think is practiced anymore, but definitely there was a role for that back, but I don't think it's at least not commonly used.
Thank you.
There's no more questions in the chat box.
I think, I want to ask Santhosh, is there any drugs which can actually prevent liver toxicity of alcohol? For example, you are told that the mechanism involves glutathione and all. If you supplement glutathione, can it actually protect the people from liver injury?
Thank you, sir.
But now there are so many preparations available in the market with the glutathione. Now they are actually behind you, every doctor saying that this is because the mechanism involved is there is a role theoretically by glutathione. No? Do you think
Yes,
it is supplementation is beneficial?
So there was a randomized control trial published in NEJM 2011 that looked at NAC supplementation, which translated into high glutathione in the system during day 1 and day 2 of admission in the ICU, in the ward or ICU setup. They showed that there was 1 month improved outcome with the group that got NAC infusion. But this 1 month outcome did not translate into 3 or 6 month outcome. So when the alcoholic hepatitis comes in, we also in practice occasionally give oral NAC for these patients as a mode of supplementation of glutathione, but I wouldn't think we are there in present day to have any literature to say that glutathione along with alcohol may be protective or decrease the harm of alcohol. So surely we cannot advocate that.
Yeah, thank you. Palaniswamy, we have to wind it
There are
up.
no further questions. I would like to thank both Dr. Vijay and Anthony, Vijay and Santhosh for the excellent lecture, the interaction. Over to Dr. Mathew.
Thank you so much, Palaniswamy. It was wonderful. Thanks for moderating your session so well. And Santhosh and Vijay, they were a wonderful presentation, and there was some technical glitch with the Vijay. I think, the sound was little not audible for some time, but anyway, the content was wonderful, and we really thoroughly enjoyed. And I am sure there'll be if the participants also would have benefited by this. And I thank GAPIO for this platform, and IST is happy to disseminate science. And I thank Dr. Eapen for suggesting Santhosh and Dr. Vijay, and your selection was fantastic, and they did so well. Thank you so much. Thank you, Jitendra and Musugal, for the platform. Thank you so much.
Thank you. Thank you, everyone.
Thank you.
Thank you. Thank you, sir.